Okay. Well, if you want to start by introducing yourself.
Yeah, sounds good. Well, hi, good afternoon. I'm Jared Zummer. I'm our pediatric ER medical director here at the University of Kentucky. I am a ER doctor by training. I did a couple years of pediatric ER subspecialty, and so most of my practice I spend in the pediatric ER with children, and still see adults every occasion. Been here at UK for about 6 years now.
That's awesome.
Yeah.
Cool. Okay. So when we talk about pediatric patients, especially in terms of trauma, they do differ from adults, right? So what is your insight on how pediatric patients differ in terms of like physiologically versus adults?
I think the big thing, and you'll hear me probably repeat this, and a lot of us who take care of children on a regular basis, not just in trauma, but in all cases of shock hypovolemia, is how they compensate. A big thing is they have a good capacity to increase their heart rate in response to volume loss, whether it's blood or otherwise. And so they'll get tachycardic and more tachycardic right up until the end, until they get hypotensive. And so hypotension is really a late finding in shock in pediatric patients. I know when you talk about blood volume, we're talking even sometimes up to 30-40% of their blood volume before they get hypotensive at all.
Gotcha.
Which can be different than your adult patients with a heart that often increases their stroke volume a little more, which children don't do. But really why it's so important to pay attention to heart rate and also trends in heart rate, more than just isolated blood pressure, as opposed to what we're doing in adult medicine.
Yeah. So what would your threshold be, or what would your advice be to any providers who, they see the patient's tachycardic, but their blood pressure is normal? So what would your threshold be and your advice to give to them on when to administer blood versus crystalloids? Yeah,
it's a good question. So I would say first and foremost, what makes it a little more complicated, just to add another layer, is you got to still make sure we're not tachycardic for other reasons. And one of the challenges we talk about a lot is, even especially in our trauma bay, but I assume in the back of your ambulance too, the kid is there, they're scared, their parents aren't around, so they might just be tachycardic for that reason. They may be in a lot of pain because of whatever injury they have. And then, of course, in other situations, they might have fever, etc. And so trying to eliminate a lot of those factors up front, so you're doing some medicine, but also trying to console a child, get them comfortable. That's your first challenge.
It's hard.
Yeah, definitely. And so that's the first thing I'd say. I'd say make sure, or be as sure as you can, that their tachycardia is not because of something else.
Okay.
And then in the right setting, and you have an injury and you anticipate that they're losing blood, paying attention again to the trends in heart rate increase. I think still most of our practice, unless you have certain types of injury, clear penetrating injuries to the heart, the abdomen, we're still going to go with the crystalloid first strategy most of the time. But I would say after your first 10, 20 cc's per kilo, you're not getting a response in their heart rate.
Of crystalloid.
And it's getting worse. I would reach for blood early on. But I think still we're a little more hesitant. Maybe it's just because we don't have as much experience with it in peds, is to go straight to blood first besides some certain circumstances.
Okay, so definitely try some crystalloid first.
I would probably start in most cases with some crystalloid first and look at those trends in your heart rate and blood pressure. Again, if you're hypotensive off the bat and you're bleeding, I would certainly reach for blood early in those cases because again, like I keep saying, we're already pretty far down and they've lost a lot of volume. But if they're still maintaining and they're showing good signs of perfusion otherwise, I would probably go with mostly a crystalloid first strategy.
Okay.
Yeah.
Cool. We've already talked about, we've knocked a lot of these out already. Okay. So are there any concerns regarding volume overload if you're giving a certain amount of blood to children, or even just with crystalloid?
Yeah, in most of these cases, I think you actually probably on the contrary can worry a bit less than a lot of your adult patients. A lot of the patients we see that are sick with heart failure, they have whatever, bad kidneys, bad lungs. I think we're worried a little more about volume overload. Most of these children have healthy hearts. They're healthy at baseline, their blood vessels, their hearts. And so I worry a little bit less in especially the trauma patient. Now, if you see a big scar on the kid's chest, they have a history of some congenital issues, or they've been sick otherwise. The situations where we do worry about volume overload are the kids that have been either chronically anemic, a lot of our cancer patients perhaps, or the kid that has myocarditis for other reasons. We can always go slow in those situations, giving about 5 or 10 per kilo at a time, and even blood transfusion strategy in trauma, we'll start with 10 per kilo and just go slowly from there. But in most other cases, and I'm picking out the rare exceptions, you can feel pretty confident in giving that volume to the kid, and they should compensate quite well.
How fast do you expect to see those changes after someone's given blood?
Yeah, quite quickly. Again, just as we said, we get tachycardic, and I'll keep repeating that. Your heart rate is a good barometer in the setting of pediatric trauma or any pediatric insult. They should respond pretty quickly as well to blood administration. So by the time, if they've been given that volume already, we should have already seen response by the time they come to us. Yeah, it's not immediate, but near immediate.
Okay.
Yeah.
Okay. So in terms of neonates and infants, do they require special considerations when it comes to whole blood?
Not in particular in terms of, again, giving it slower, quicker. I think the one challenge is going to be just the ease of actually getting access, as you guys know, giving it. I think I saw in those questions talk about a push-pull method of administration. I think you can often give volume, whether it's blood or crystalloid, a lot faster to these kids using a push-pull method. For those that may have less familiarity with it, basically you just attach a 3-way stopcock to your IV tubing and literally pull in either whatever size syringe, 10, 20 cc's, pull that fluid, pull the blood, and then turn it and give it that way. Usually, unless you have a rapid infuser, I'm not sure what the different systems are using on their trucks. But you can give it quite quickly, especially for those little kids. When we're talking about potentially like a 10-kilo kid, you're giving 100 cc's to, or even less, it would be a quick and more accurate way to potentially give that amount of volume. Let me I'll touch first, because we're going to talk about access a lot, and IO access is a big question, something I really am passionate about. The question about getting them to the OR potentially faster, I think that is a potential, just because we don't have a lot of experience with it here. I'm not sure, but I think there's a lot of potential. So yeah, say you've already resuscitated, they've received whatever, the couple units of blood or whatever we're weight-based dosing, and they're potentially a little more stable. It will not only because and Dr. Dow may have talked to you guys about it a lot. We less and less operate on children in trauma. There's a lot of less spleens taken out, a lot of tamponiting off injuries, and so it may not be getting them to the OR quicker, but it may be they're already stabilized beforehand. So it'll get them quicker to the ICU, to the floor, somewhere where they're already going to be monitored and have more resources, and take some resources off of us so we can take care of the next kid that comes in. So I think in terms of some benefit, like that is a huge one. Maybe not always getting them to the OR, although that is possible in certain cases, but just having a stable kid. We're not dealing with the resuscitation. You guys have already started that. So huge benefit, potentially,
Okay. So when it comes to access, so in a lot of pediatric patients, we have moved to distal femur IOs. What's your thoughts about that, and what is the best way to find that access?
Yeah, it's good. So I'm a big proponent of that as well. I think the littler kids, especially under a year of age, is when I typically go to a distal femur, and maybe some even older than that. But your classic teaching, I know, is always proximal tibia. Just finding the little kids sometimes, we're dealing with very thin bones, easy to go through. More distal, and if they're very clamped down, you're getting a more proximal access in the femur. And because we do worry about growth plates and things in the shoulder and the humerus, the distal femur is a really good access point. So if you go 1 or 2 finger breadths just above like your patella, you can go pretty midline as well. You don't have to worry too much about what side of the bone you're in, and go perpendicular in the femur. That'll get you good access most of the time. I mentioned humerus access, and you'll hear different resources tell you different things. 10 years old, 12 years old, maybe even a little bit older, that humeral head growth plate closes at that time. So there's always that risk that you're putting in an IO into a growth plate. Now you have the most unstable patient, maybe they're in peri-arrest or arrest. Okay, if you need access there and you don't have another source for whatever reason, they're burned or something, do it. I'm not saying it's better to resuscitate the kid and do something than nothing. People can yell and cry about their growth plate, but they've made it, they survived, right? And I know you guys, we talk about that a lot, right? But at the same time, I think that site is for most kids a good preferred site. I think as you get older, the toddler or even a little older, the school age kid, 5, 6 years old, I wouldn't hesitate too much about using the proximal TOWB.
Okay.
But I do like that, and I like that you guys have changed your practice as well.
It's awesome.
Yeah. That's just anecdotally. I don't know if there's a lot of evidence, but I find in the infants, especially those little chubby babies and stuff, the distal femur is a very good spot too.
Awesome.
Yeah.
Okay.
And a secure spot as well.
Right. Yeah. What about IVs? What's your preference on those? Yeah.
So again, like if you can get a good proximal IV, large bore, great, do it. We asked about, is there a limitation to giving blood through a really small line? No, but like any IV, any volume administration, you're just going to limit your rates of administration. So they may just not get it fast enough. So if you put head to head, like a 24 gauge IV versus an IO, there's a good, and you need a lot of volume. The IO actually may be able to administer faster, but I wouldn't say that you can't do it through another access point or even a small IV if that's all you have. You just might be limited in how quickly you can deliver it.
Okay, great. So what kind of medical calls would you expect us to be delivering whole blood in?
There are fewer and far between for sure in pediatrics. We don't see as many of the GI bleeds and cirrhotics, where I think that'll be a lot of your medical condition to give in adult patients. Every once in a while we do have a patient with liver disease, portal hypertension that may bleed. But I think most commonly are going to be some post-op patients, especially the one that comes to mind a lot is our tonsillectomy, post-tonsillectomy patients. Just because of the vast number, but also they're at higher risk. So the more classic case you'll see is the kid that's about 1 to 2 weeks post-op from their tonsillectomy. That's often the time when some of the scar tissue comes off. And usually it's a superficial bleed and they stop either already by the time you're there spontaneously. We use a lot of TXA, nebulized TXA now in our department. So if that's part of y'all's protocol, it's great. I would administer that early. But if they are actively bleeding, vomiting blood, it's unsafe to even put a mask on them. Those are kids that if they're continuously bleeding, they can get really sick fast. And besides airway management, early blood would be another thing to consider. So that's a good patient population for sure. It's rare that we see, like I said, GI bleeds or pulmonary bleeds in kids. If there are specific conditions you guys want to know more about, I'd be happy to answer. But those post-TNA patients are the one that comes to mind because I have vivid memories of some bad bleeds, and that's helpful. Did you all jump to blood? Yes, for sure. It's access. TXA, whether it's nebulized, in those kids you really often can't because there's such an aspiration risk. So IV, TXA we'll use for those patients, and then early blood is actually, that's probably the patient that I'd use it on. But like locations of massive bleeding in kids, not so different than adults. We talk about the chest, the belly, the thigh, in the street from an extremity wound. But the one case that's a little different, kids can lose a lot of blood volume from in their brain, actually, for intracranial bleeds. A little different than what we see in our adult patients. Usually, like an epidural, subdural, maybe they'll be hypotensive, but not from blood loss. Children, especially the really young children, they can develop and expand pretty large bleeds. A lot of it maybe is because their fontanelles are open still. Or just their size, but they can actually get hypovolemic from an intracranial bleed. So that may be another situation that's a little different. I don't know how often I've transfused for that, but it may be another case where that's the case. What are some signs that you see with that would indicate shock? Essentially the same stuff. We talked about increased heart rate, hypotension, but certainly mental status, perfusion, cap refill. one of the things we do consider a lot is the kids' mental status. So kids should be wild, crazy, crying in the back of your ambulance. If they are calm, you've actually either done a really good job and you're very calming presence, or you need to check on that kid because something might be going on.
Okay.
Yeah.
So if the heart rate's high, should we, talking about how they're going to be tachycardic, whether that be from anxiety or from pain or et cetera, should we start with pain management and, a calming presence? Yeah. To kind of manage that?
I would. And you're going to be doing a lot of these things in conjunction and kind of prioritizing depending on their need. But I certainly would. If a kid has, especially like even as simple as immobilizing an extremity, splinting early, it's huge, huge, huge. And you may see a big difference. I think it's one simple thing you can do that we often forget. And we do it in the ER too. We'll leave the mangled extremity because we're doing other things. But yeah, that'll give you a good indicator if they're tachycardic because of that pain. And then, we've moved a lot to usually giving either intranasal meds, either fentanyl, just because of the good hemodynamic properties, or if you guys have moved to some subdissociative ketamine doses, that's fine. As long, again, the caveats, if we're really concerned about their mental status, head injuries, it's one that I would at least be a lot more cautious about. I'm not saying you, again, weigh risk and benefit, but it's a little harder to monitor their mental status that way, especially with high doses of ketamine. And so that's a challenge with that. But yes, I would certainly treat them, especially if like it's kind of a borderline case and I really don't think they've lost that much blood, but they're getting pretty tachycardic. Go ahead and treat the pain, especially if you identify some painful injury. And I think it'll give you good insight.
I'm not sure if we kind of touched on this one. What are some early signs of hemorrhagic shock that are often overlooked?
So they can be subtle. So they'll clamp down, like I said, but they'll also, and I've reiterated this like 4 or 5 times maybe, but it is so important. Just increased tachycardia is a huge one. I think we're so trained to focus on blood pressure, especially when we see adult patients, that we sometimes forget that kids can lose that much volume and not be hypotensive. And so I'll say it a few more times, but heart rate increasing despite other measures, pain control, crystalloid, whatever, that's a concern. And then just what you would do in an adult patient, but sometimes more subtle, so their capillary refill, just how pale they are, and then again, their mental status can be a good indicator that they're not perfusing their brain properly.
We've definitely talked a lot about tachycardia.
I'm going to talk about it a lot, especially in it's what we see with our trainees, especially our residents, our surgical residents that take care of adults primarily. We've had kids getting tachycardic kind of overlooked, even sitting in RER for hours, and so something that I just kind of hammer home because of the importance. Because when they're hypotensive, you're already kind of chasing your tail, and it's pretty late. I'm not saying we always have to administer blood like immediately when they're tachycardic. Again, I think we have time, we can figure out what's going on, but in certain scenarios, or if it's not improving, it's definitely one to think about.
What are some signs of internal bleeding that aren't clearly overt after they've been in some kind of traumatic accident?
Yeah, for sure. So again, those cases, they're not bleeding out in front of you, or they don't have a huge arterial wound or a big scalp lac or something, and you're not seeing them bleed. Obviously in the adults and kids, we think about the belly, we think about their thighs, their pelvis, their chest. Kids, because they're small, and again, you may not see this and overlook it. Seeing a lot of kids with bad intra-abdominal injuries, solid organ injuries, you'll see their abdomen get distended in front of you. So that's one I would pay attention to. Like it's simple enough. Look at them. If it's increased in size, it's rare that it would be from something else. Crying, they can distend their stomach a bit, but they shouldn't get a lot of lower abdominal distension. So that's a huge one that I'd pay attention to in the setting of suspected bad blunt trauma and their vital signs. Pulmonary trauma, I think you're going to see it more easily probably. They'll have more difficulty breathing. They may be hypoxic. They may cough some frothy stuff up. I think that'll be a little more obvious. And really, I can't count on one hand the amount of times I've seen that much blood loss from especially a blunt chest trauma. Penetrating trauma, different story. But yeah, definitely the belly, look at that. And then the same thing with their thighs. If you see a thigh and it's getting big and firm in front of you, and really prominent, there's a chance they've lost a decent amount of blood there.
Okay.
So definitely a good one. If you have time, look at their genitals, see if they have a lot of bad pelvic trauma, vaginal bleeding, etc. It's one that's overlooked a lot and can be significant. And so I talked a lot about, and I hammered home this tachycardia point, but just remember, kids, again, get tachycardic for a lot of reasons. We're talking about worsening tachycardia in the setting of suspected hemorrhage. Yeah.
Right. Okay.
Yeah.
Are there any questions you feel like we should be asking?
The kid, sometimes with pretty significant internal trauma, may not have a lot of external signs of trauma, not a ton of bruising potentially. Usually when we're talking about significant blood loss, probably you're going to see some, is, you have to have pressure between two like solid parts, whether it's your spine or a seat belt in your spine or whatever in the chest. But yeah, they less often break their ribs, they're more pliable, and so it's possible you don't see a ton of bruising and they could be bleeding quite a bit.
Okay.
So yeah. That's probably true about that diamond in kids though, and especially, we know they're already susceptible to get hypothermic quicker, and so everything's just a little more quicker and pronounced. Yeah.
Gotcha.